Hello, good evening, everyone. I am Dr. Francis Roy. I am the chairman of the SHCO forum, and I welcome you all to this fourth session of Boost. Boost was started with the intention of strengthening um, the healthcare organization of the small healthcare organizations, which are like the forefront warriors of healthcare in our India. And as you know, CAHO's heart is with patient safety, and we had a privilege of getting this program being done with our leadership's commitment and their advice and help. And we have done three programs very successfully. The first three programs has been on administrative aspects, and we thought the fourth program we will move on to clinical aspects. And as you know, even though it's a small practice, both uh, medication safety and safe injection practice, it makes a huge difference in saving lives, especially uh, in a way strengthening the entire healthcare system in all. Today, we have two eminent speakers, uh, Dr. Britto and Madam Nithya. And unfortunately, Dr. Devanand is not here, and Dr. Arjun, who is the executive director of New Healthcare in Pondicherry, has graciously accepted to moderate this session. So I welcome you all and thank you once again. Arjun, I think you can take over the session.
Very good evening to all. Um, the first topic of today will be prevention of medication errors. And the speaker of today, um, the speaker today is Dr. L. Britto Duraisingh. He is the head of pharmacy services at Ganga Medical Center and Hospital, Coimbatore. And he will be speaking for 20 minutes on prevention of medication errors. And following the talk, we will have some question and answer session. So over to you, Dr. Brito, and we'll look forward to a very interesting session.
Thank you, Dr. Arjun, and thank you, CAHO, for the opportunity to share my experiences on medication management and safety. Can I share my slide? Sir, is that visible?
Yes, doctor.
Yes. So, first of all, in my topic for the next 20 minutes, I'd like to narrate like what is a medication error and what are all the different types and what are all the basic contributing factors and how can we work on preventing it. So, medication error, it's not a big deal. So, I always, whenever I take a class for our team or wherever I go, I'll tell you few examples. Medication error is something where and when the qualified physician writes and then the qualified nurse transcribe it to pharmacy, and when the qualified pharmacist dispensed it, and again when the qualified nurse administered it, and then the qualified team monitors it and documents it. When something went wrong in the controlled environment of the highly qualified professionals and related to the medication use, that's called as error. See, for example, in all the hospitals, when you look at the steps, patients gets in and they meet a doctor review all their clinical profile and physically examine the patient, and they'll come to the final diagnosis and they will start prescribe the medicine. So the first opportunity for committing an error is when you are reviewing the patient's history and when you are coming to the conclusion before you start writing the prescriptions. So the first steps happen when you are writing the prescription. Second, when the patients get admitted into the hospital, even though the prescription written in the drug chart, again it will be transcribed or electronically intended to the pharmacy by the nurse. So the second chance can happen when the nurse transcribes the prescription to the pharmacy. And third opportunity for an error, it's when the pharmacist receives and dispenses the medicine. And then the fourth, again the nurse receives and administered it, again the documented it. So this is what the outflow. Assume that in all the different outflow, all qualified peoples are involved into it, but when something went wrong, then that is called as medication error. Always when you look at the definition of medication error, it is any preventable event that may cause or lead to inappropriate medication use. See, the word is preventable event, we need to underline it. So medication errors are preventable or avoidable when we have the very standard practices into our center. And I told you the diagnosis happened, the prescriptions written, dispensed by the pharmacist, administered, and again the patient gets home well, or it will be monitored, documented. So this is all the steps from the medication errors factor. And we look at the people or the person or the process involved in the medication practices. First, the healthcare professionals, they may receive the information from the patients. Sometimes it may go wrong. When they write, sometimes it may go wrong. When they think of practicing the medicine from the standard guidelines, it may go wrong and it may be communicated wrongly to the patients. So the first people are us, either the physician, either the nurse, either the pharmacist, either the patient assistant. So this group of populations are involved in the process. When something goes wrong with these people and their protocols, it can lead to medication error. Second, patients, the complexity of the patients, and then when the patients comes from the polypharmacy, they have multiple diseases, multiple drugs, multiple doctors visit. Recently, a couple of days ago, I have reviewed the patient where they have admitted with us for the diabetic foot ulcer, and you don't believe they met nearly 2 to 3 physicians. They went there and they got their prescription, and finally they went to the surgeon, and finally they admitted into the another hospital for some infusion of to prevent the clot in the vein, and then they finally referred to us. When I took over the prescription, within a month, within a day of 15 to 20, they reviewed multiple physicians and they got multiple prescriptions. Though it is a high complexity in the recent days, even though the patients reached us and we do best, but they may take something without our knowledge. So the second common cause is from the patient. And third is work environment. We all tell, even the busy setup or the small setup or the medium setup, the common term from everyone, what we hear is, I am busy, I am busy. So my patients are sick. I have no nursing faculty to deal with the patients because the crowd, this, that. When there are a lot of distractions, usage of mobile phones, taking over, handing overs, there won't be the very standard protocol between us. So the complex work environment also can cause or contribute the medication errors. And the fourth, people involved is medicine. When if you're not having the very good pharmacy control, if you're not having the very good inventory control, you can have 4 medicine and 4 molecule with a 1 letter different. You can have, I used to always comment, I don't like to blame the company. For example, if the physician writes Dolo, even the pharmacy guy can give. If the physician writes Dole, missing O, we can give some medicine. If they write do, we can give. If they simply writes D, also we can give. That is what the standard of medications in our hospital. We have a brand called Tramazac, Tazomac, and then we have a brand called Stalix. The medicine, the sound similar, it looks similar, it labels similar. There are a lot of confusion is happening while we are filling the medicine, dispensing the medicine. If you're not having very standard protocols on the place, it would be very, very difficult for us to give the right medicine dispensed to the patient. And then there are different tasks involved. If you're having the whole digitally evolved unit, you are ordering. When you type some drugs, for example, Dolo, you can get Dolovin, Dolonex, Doloper, Dolo, you will get 100 drugs. If you write glycomet, glycomet SR, MR, ER, all the Rs, D, everything will come. and then Amaryl, M, M1, MV2. When you are ordering and when you're monitoring, when your task is little complicated, that is a common factor to commit an error. And again, the same thing will come for computerized information system. These are all the different factors it can contribute for error. So number one, you must understand what is medication error. Medication error is nothing where when it happens somewhere, when it happened in the controlled environment where all qualified people like us are there, when something goes wrong with the medicine, it's called as medication error. And then when you look at the process, the prescription, transcription, dispensing, administration, and monitoring documentation. These are all the different steps involved in the medications practices. And then if you look at the persons or the process involved, we like the healthcare professionals involved. Either the doctors can write the wrong medicine or the wrong dose. The pharmacist can dispense the wrong medicine or wrong dose with the wrong information, with the wrong label. The nurse can administer the wrong medicine to the wrong patient, the wrong dose, wrong route. So we are the essential factors are contributing the errors. And then the patients. Some patients, they will have the multiple medication, multiple comorbidities, the complexity of attending the case. It would be the difficult factor where we have a lot of errors. And in my future sale, I will add the special population also. And then the work environment, when you have a lot of distraction, when the one nurse handle 10 patients, when the one nurse has to handle the OPD and IPD, when you have multiple handover sessions into your place, this is all very complex environment where the chances of errors are more. And then when your pharmacy has multiple brand with the similar names, multiple brands with a similar look, again it is the cause. And when you're having the multitask to the single people, the same to write, intent into the system, and then again they need to receive the multitasking, system cause an error. These are only a few factors where you need to work very closely if you wanted to minimize the medication error in your center. And when you look at the prescription error, I would always say, I'll always request even my clinical team and to any doctor whoever listening that please fill all columns of the prescriptions. For example, the dose, and then the route, and then the special information, and then the specific duration. Write the drugs legibly. When you complete these factors, when you complete the prescription, the chances of errors are very low. So that anyone can easily read, anyone can easily identify the dose, anyone can easily identify the route. For example, once daily, or how on every Monday, or before food, after food, and all the information. So my kind request to minimize the prescription error is fulfilling the prescription needs. When you give the complete information to the next clinical team, they don't need to wait to check and confirm again with you. It will save a lot of your time. They will save your patient by giving the right medicine, by dispensing the medicines rightly, by administering it rightly, and document it rightly. So to the inpatient, if you wanted to reduce the medication error, please fill all columns of the prescription with complete legibility in capital letter. Number one, when you are being in the OPD setup, so whatever you writes or your assistant writes the prescription, before you sign, review the prescription at least 30 seconds. Whether I have written it rightly, whether all the elements of the prescription has been filled, whether my patient will understand, my pharmacist will dispense the right medicine. You have this concept into your mind, and you will please take 30 seconds extra to review the prescription before signing. That has a lot of value on reducing your OPD prescriptions, because again, your prescription hold your hospital name, your registration number, your seal and sign. It is your privilege, and again it is a legal document. When it goes to other, it even files the complaint against you, and it decreases a lot of value, and it will bring down our value to the society. So when you reduce the prescription error, please write all columns of prescription, including the specific information and legibility with capital letter. And OPD prescription, at least review 30 seconds extra before you sign. That bring down all the errors rate in your medication practices. And transcription, again, So when the prescriptions write correctly, your transcription goes correctly. This is predominant part of the nurse. I'll always request the nursing team to look at the prescriptions. If you did not understand anything from the prescription, please do not transcribe it. Seek a help of your senior nurse or your supervisor or your educator or your clinical team or your pharmacist or your prescriber. Check once before you are transcribing it. And please do not transcribe the prescription to pharmacy without doses, without, if you're writing paracetamol, you put like 4, what the pharmacist can give, whether they will give injection or tablet or syrup or suspension, and what doses they will give. And commonly we will have the prescription to pharmacy for enoxaparin 4. How enoxaparin 4, whether it is 20 mg, 40 mg, 60 or 80, it's difficult. And give piperacillin tazobactam 2. When the prescriptions are blank, it would be again difficult. It takes a lot of your time for the confirmation. So when the prescriber writes everything correct, it is easy for the transcriber to do that. When the transcriber feels not conforming the drug, it is their primary responsibility to check with the prescriber or other clinical team. They can check with the senior nurse or check with their clinical pharmacist to get it confirmed before they're transcribing it. It would be easy for their pharmacist to dispense the medicines rightly, and it would be easy for them. It saves a lot of time. So everything to be checked before itself. Once it is done, and it is done with a medication error. And again, whenever you receive the verbal order, please do not encourage verbal order when the physicians are available. Please do not, the nurses do not call all the time to get the orders of insulin. Whenever you get the insulin for the first patient, the doctor might have tell you 13 units. It means 1 3. And the second patient, they can tell you 30. It would be very difficult for you to get to know whether it is 30 or 13. And sound alike medicines, whether it is Tamazoc or Tasmac, or it is Talix or Thalix, or it is Gabapin or Gabavin. There are a lot of confusion can happen. It would be again make you to understand very hard to transcribe it. To minimize this verbal order, you must have the policy of repeat back or read back. Once you have written it, you try to read it back to the clinical team to get it confirmed. For example, if you're writing paracetamol, tell your clinical team that I'm writing Paracetamol, paracetamol I'm writing, P for parrot. See, whenever even sometimes I'll get a call from the senior consultants in our center, I would read them back in the way that the error can't happen. Because we have a lot of combination medicines of painkiller. One of the paracetamol available separately, and it available with tramadol, it is available with brufen. We have a lot of combination. Even the one word missed, the additional NSAIDs has gone. So it is always ideal to get it confirmed before you are transcribing the medicines to the pharmacy. And dispensing, and the major cause of dispensing error is the careless, and it's a lack of protocol adherence by the pharmacist. Whenever you receive the prescription, have 2 to 3 seconds extra to look at the prescription whether it has been prescribed for that particular patient. For example, you call the patient by the name. For example, if I am Britto, my prescription is coming to you, and you can say, Britto, is that you? Right. So you receive the prescription for the right patient. When you fill, do double check, triple check. Whenever you have the high risk medicine. So I request you to have the high risk medicine list in your center. And whenever you have the high risk medicine to your pharmacy, always do 2 independent check. If I am filling the drugs, I wanted to give the tray to the next pharmacist to check the medicine before it gets dispensed. Even it is a small sitagliptin metformin, 500 mg or 1 gram. Do double check. Whenever you get a thyroid, because whenever you get a thyroid, the same bottles will be there with a different strength. 12.5 microgram, 25 microgram, 50 microgram. When instead of this box, if you take that box, gone. The wrong medicine reached, the clinical outcome, it's again the questionable. So do double check, have the good protocol, have a good leadership team, and please be not, distractive. Do not use your mobile phone when you're handling the patient, when you're taking the medicine. This would be the very tough situation. When something is reached out of your hand to your outpatient, they may come after 30 days. When you give wrong warfarin dose to the patient, they may end up with bleed. when you're not giving the sufficient dose of warfarin, they may end up with stroke.
Excuse me, Dr. Britto, this 10 minutes more.
Yeah, I'll finish fast, doctor. So anything can happen. So do not be very distractive. Spend little more time in each and every process. Spend 2 to 3 seconds extra. That saves all your time to prevent the dispensing error. And as you told you, lookalike, soundalike, and please have the list of lookalike, soundalike, and high-risk medicines, and have a definitive protocol of all the things and work together to prevent the dispensing error. Administration error, again, it all happened when you are not having the very standard protocol, what it has been written. So when the prescription is written correctly, when the right medicine reaches the patient, it is all on the nurse's hand to go for the administration. Please do check thrice when you deal with a high risk medicine. Please check twice when you deal with a normal medicine. Do not give medicine without check. This is the mantra. When you deal with the high risk medicine for the administration, if you are taking the insulin, show to the next nurse that I am going for Actrapet. I am going for Mixted 3070. Show them that, get it confirmed. See, I have taken 12 units as prescribed. I am going for injection. That minimizes your administration error. And please always coordinate with your clinical team and pharmacy team for the administration for the longer infusion drugs. For example, amphotericin B. When you go with that, you have to have a pharmacy incorporative administration techniques, and it has to mix with 5% dextrose to be infused over 4 to 5 hours. There must be the protocol that must be properly educated to all the nurses. Have the separate infusion administration policy that must be spread to all the areas, and that has to be educated to even the newly joined nurse. So for in your setup, you may deal with 10 to 15 drugs very commonly. Have a checklist, how to mix, what to use, how to infuse. For example, if you are taking cefuroxime of 750 mg, it has to be mixed with 20 ml of water for injection over 5 minutes. It is a point because wherever you go, there is a cefuroxime. That must be incorporated into the hospital information system. When the nurse has the doubt how to infuse or inject this, let her log in, get the infusion things clear. They can go for the right administration and then to go for a documentation. So that avoids going for the wrong drug, wrong time, wrong dose, wrong patient. You know that when you do double check, triple check, when you have the proper protocol into the place, these administration errors are minimized. And documentation, again, nowadays the common problem is they are documenting simply before administration, or they are not at all administration, the documentation is happened. Please do silent checks for that. So what did I do one time was like I alerted my clinical team. I have 20-30 pharmacists, and I alerted my team. I just selected the liquid orals. So that particular day or previous day, I got a list of syrups dispensed from the pharmacy to our inpatient. I went to that area and I checked if it is opened or unopened. If it is opened, how much ml remains, and I inquired the nurse how much ml she has given. So when you do the silent audits, and it will give you the original data, again, it's not like fault finding or blaming the other team. Have a data, go and educate them, make them to understand what went wrong. It is not just for the documentation, the actual purpose to be met because it's medicine. And in the special situation, I'll bring pediatrics and geriatrics. Pediatrics, you have to calculate the doses and you have to use a lot of measuring things. For example, if the 120 mg of paracetamol per 5 ml, if you wanted to give it to the baby, they may write 2.5 ml. So you can get 5 ml of 120 mg, you need to use only 3.5 ml. Again, the error can happen. When the calculation of doses, when the pediatric patient, you need to calculate 10 to 15 mg per kg per body weight. And again, you may give the wrong dose. Whenever you are addressing the pediatric population, you need to do a lot of calculation. You need to do the dosing. For example, we have a brand called Ketorolac. It will be available 30 mg per ml. But pediatric babies, we may give 10 to 15 mg based on the need. So they need to take 1 ml diluted with 10 ml, and they need to take 6.3 ml. It never happened. So it is incorporated pharmacy service on the medication administration practices and giving the recommendation to the clinical team. We pharmacy team will write. So dilute with 10 ml, take 6.3 ml, go for administration. So this kind of thing, this special population pediatrics need to be looked very closely. When you have 10 pediatric patients, concentrate them on more, even though they will be on only syrup and lansoprazole, it has to be addressed very carefully because there are a lot of administration errors can happen in that area. And the second thing is geriatrics. They will come with multiple drugs, multiple comorbidities. Dose adjustments may require, the nephrologist will come and tell you that fluid restriction, where you cannot always load 100 ml over 1
Dr.
hour
Britto,
of
5 minutes
infusion.
left.
Yes. So whenever you address the geriatric population, you need to be very, very careful because they will be a number of tablets. They may tend to forget the medicines intake. You need to go, you need to make them to take, and then you sign on that. And critical care. Critical care, they will be having multiple drugs. You need to infuse it. You need to properly label it. There are a lot of drug interaction can happen, and you need to have a very, very close monitoring on that. And the one step, what I would suggest to you is have a separate nursing team. Whenever the drug administration time comes, this quote can be put: do not disturb nurse on drug rounds. You have to have a medication safety nurse, and her primary responsibility to look at the medication safety practices. And then I would recommend you to have the clinical pharmacy service in your ward. So the role of clinical pharmacist is to monitor all the factors into the medication administration. I would require your clinical team to do a lot of audit on prescribing, transcribing, administration, dispensing of medication practices. Have a good committee, present it, do root cause analysis, avoid all the errors that will prevent the medication error in your setup. Thank you so much for the opportunity.
Thank you, Dr. Britto. It was a wonderful session. To start off with questions, I would like to begin asking you a question. In your experience, what are the most common causes of medication is that you have seen in hospitals?
So I would feel that the most common cause is our, not taking much responsibility on our head. For example, I would give you an example. Well, one time when our patients prescribed with posaconazole, that is antifungal drug. So the patient was prescribed with posaconazole 300 mg, and then when the nurse tried to intended it, she could not get posaconazole because it was written the generic name. She don't know to check the generic name into the system. So what did she do was she called the pharmacy and she asked like what I can give indent for posaconazole. From the pharmacy, the smart guy replied the brand name of fluconazole. The difference is posaconazole, fluconazole. Something has happened. They did not even reconfirm it. They did not be much responsible on it. And they just told them that. Again, the nurse had asked, sir, it has written 300 mg. And my pharmacist told, like, it's not a problem. Give 150 mg. The confidence what they have before they did not check it. That has to be avoided when you wanted to have the error-free environment. And everyone must be responsible right from the prescriber, transcriber, dispenser, and administrator. When you have the responsible team with proper protocols on place, this errors, even you can make it zero.
That was a great example you gave. And with regards to that question, do you think this error occurs more common in a high resource setting versus a low resource setting, or what is your experience?
In the high resource setting, we may have a lot of protocols on the place. And again, it would be difficult for the protocols to reach all the people. In the low resource setup, it would be easy to make a protocol and most probably it can easily reach all the people. So I would say we cannot different these things. So that it is equal. But in the low resource setup, there is a lack of protocol. In the high resource setup, there are a lot of protocols. When they share the protocol with the low resource setup, and then when it reaches widely to all the people, and the safety of medications are enhanced and medication practices are enhanced, I would recommend the low resource setup to have or hire the protocol from the high resource setup, and that protocols to reach even all the healthcare professional in your center. And even the low resource setup can make their error rate is 0. And high resource setup don't have the complicated protocols on this place. That would be very difficult to reach all the peoples, and we have a lot of non-compliances on the protocol. That is the difference. So low resource setup not having the protocol, high resource setup having the complex protocol. Low resource setup, they have all the standard people. The people will be there for 10 years with them, but they don't know. They only know what the doctor write, what to give. There is no much upgradation and standards in their places. High resource setup, every year we will generate new protocol, but we need to talk to the new people. That is a challenge for us. When the low resource setup has the good protocols like high resource setup, and when they have invest the program like this to reach all the people with their protocol, their error rate will be 0. When the high resource setup has minimized the complexity of the protocol, but the protocol should be on the clinical setup so that they can reduce the complications, they can bring down their medication error rate.
And do you think early adoption of electronic prescription and electronic health records will make a difference in such a setting?
Yes, yeah. I would always recommend to go for electronic prescription setup. You can control it. For example, I would say like in your hospital, you can have at least 10 drugs which should not reach without the doctor's knowledge. You can restrict, that even they cannot make an intent without the doctor's knowledge. I would tell you, I have injection alpostin, which should not be put to all the normal patient. We have a brand called Althrocin. Alpostin. When the nurse check Althrocin, she will put alpostin. We have a brand called Posit and Poshiflus. Posit is etoposide. It is a anti-cancer medicine. Poshiflus, it's at least a normal saline. You can control. What I did was like I completely looked at the near misses, what is wrongly intended. I have generated the list. I blocked for online indenting. I have a systemized control. And then weekly once methotrexate cannot prescribe daily once. I have a systemized control. When you wanted to improve the safety, early adaptation of digital prescription, it's always essential. Even again, when you look at the pharmacy as a financial setup, when you go for the e-prescription, you cannot write the non-formulary medicine. It directly increases your revenue. The prescription can't go out. Patient cannot take the prescription, they can walk out. They need to go and meet your pharmacy and explain the reason for not procuring the medicine from us. That again, the data to be discussed in a meeting, that can be worked well on your discounting, on all the process, you can generate the revenue out of it. So I always recommend the early adaptation of digital standards is advisable.
There's a question in the chat box that somebody has asked. They've said if two drugs have the same generic name, and once a drug is dispensed, but if the other drug is dispensed rather than the one that is intended to, and that causes a adverse drug reaction, then is it a dispensing error? That's what they've asked.
Definitely, it's a dispensing error because, the question is, it's a different molecule prescribed, different molecule dispensed. That is what I understood. When you are deviating the prescription practices, so even though whatever the doctor prescribed, the pharmacist should only dispense the medicine what they prescribe. If you find any deviation, if you feel like the non-diabetic patient prescribed the diabetic drug, it is the primary responsibility of the pharmacist to get back to the prescriber and check with him what to be dispensed, and then only we can dispense it. When we are not authorized to take the advantage of dispensing the medicine what we like. So to the pharmacy team, it is the dispensing error. If we have any doubt related to the prescribed medicine, that has to be double checked with the prescriber before we are dispensing it. That is the right practice. Or you have a system, you can have the assistant, the electronic communication, you can put a WhatsApp message to your doctor, or you can have the separate team, someone can look at your prescription to address it. If you don't have a time, you can take the picture and you put it on the WhatsApp, and you will get the answer. So it is definitely the dispensing error if you dispense the wrong medicine.
With regards to this question, do you think AI in the future will play a role in in helping reduce medication errors, such medication errors?
Yes, yes. AI can again AI it is a database there, and whatever we put and it will get we can get get in return. So A, when we are giving the right information, we'll get the right thing. So I would feel like AI can work on inventory management into the pharmacy rather than the prescription generation. So prescription generation, it needs the manual intervention of the clinical team and then the pharmacy team. But AI can analyze what to be stocked, what not to be stocked, what to be ordered, what's the slow moving. It can predict the sales well in advance. It can tell us so that we can be more profitable in the pharmacy. But for prescription generation and dispensing, AI can help, but the manual intervention of the doctor and then the manual intervention of the pharmacist, it can't be replaced.
Just one last question. There's a lot of fear that people have, um, with regards to litigation. So there's a lot of fear of litigation, and there's fear there'll be blame. And how do we, create a culture of with safety in hospitals, and also build a culture where we prevent errors and also a culture of safety?
Yes, it is a very challenging question in all the forums I'll get. So it is all depends. See, being as a head of the unit, I can be a little bit free for my junior fellow pharmacists to come and talk to me. When something had happened, for example, recently what happened was my pharmacist billed shell call and given shell call HT. And then whenever we do the regular check, we found it's a difference. And he directly came to me and he told me like, sir, I did something wrong. And nothing we did. We called back the doctor. We informed that, sir, something has happened. Is that really going to harm the patients? So he's the one who need to decide on the prescription rights or wrong. He said nothing, Britto. And then next minute we called the patient and we told them that we did something wrong, but do not fear. I checked with the doctor. And see, medication errors, the human can have the tendency to commit an error. It's all depends on the way how we are accepting it and making this stepping the way forward to preventing it. And we need to have the just culture. We should not blame. I would recommend all the heads of the unit, or you are the senior pharmacist or the senior nurse, do not be very harsh to your team when they commit something wrong. Instead, be as a person where they can come and approach you very easily when they commit an error. So it would, for in case of medicine, how much fast the person is coming and reaching you, that much you can prevent the error to the patient. If the person is coming you 10 hours late, there is one chance of taking the one dose of medicine. If it's coming within 2 hours, you can call and you can stop taking the medicine. So it has to be create the just culture by the administrative team. That's what I can suggest.
Thank you, Dr. Britto. It was a fantastic session, and I guess a very eye-opening session to a lot of people here. And we look forward to many more sessions with you in the days to come. Thank you. Thank you very much.
Thank you so much, sir. Thank you for your moderating my session. I thank CAHO for giving me the opportunity. I thank Dr. Francis and Nisha for supporting me and making me to be as a part of this team. Thank you so much.
Good afternoon again. The second speaker for the day would be Dr. Nithya. And Dr. Nithya is an anesthetist by qualification. She has worked as a clinical observer in the United Kingdom, and she's worked with TACT Academy um, as a program as an academic coordinator. TACT is the first simulation-based center in India, based out of Chennai, and she worked there for 9 years, and then she went on to start her own company. She founded the Skills for Med company, where she's currently the CEO, and it's a company that upskills nurses in practices and skills. So we'd like to welcome Mrs. Nithya Pari today to uh, to take the second session for the day, which is safe injection and infusion practices.
Thank you.
Over to you, Dr. Nithya.
Thank you, Arjun. Thank you for that introduction. Can I share my slides?
Yes, madam.
Yeah. So a very good afternoon to all of you. And at the outset, I'd like to thank CAHO and Dr. Roy, who's the chairman of this webinar series for Boost, for giving me this opportunity. I'm so glad to be here with all of you today to talk about safe infusion and injection practices, which will help to build excellence in small healthcare organization. And so let me start my presentation. Yeah. So what's the critical need for safe injection practice? So all of us know that, as you all know, CAHO is talking so much about patient safety. So we need to also focus on safe injection practices. If you can see this data here, but every year, 20 lakh patients die suffering from healthcare-associated infection. And in a hospital, and patients are admitted, 1 out of 20 patients, 5% of the patient gets healthcare-associated infection. So once they get have the infection, so they get admitted for some reason, and they land up with the infection, and ultimately the hospital stay increases by 7 to 15 days, and then the cost of treatment goes up for the patient. So they have a big hole in the pocket, and what is to cost them 15,000 goes up to 50,000. So ultimately the patient and the family suffers. So it's very important to make sure that we do safe practices. So unsafe injection practice can be very serious threat to the patient and to the healthcare workers. It's also always very important to think of the healthcare worker as well. Always we think about safeguarding the patient, but you also have to safeguard yourself by doing the safe injection practices. So there's a unique challenge in all the small healthcare organizations. So it's not excuses given by the organization. It's really, they have a lot of challenges they face in everyday life, by, when they want to practice safe injection and infusion practices. So what are the challenges they face? Most common and important reason is resource constraints. So they have limited supplies. They have budget issues where they can't, order for very, whatever they want to order, they can't order because they have budget constraints. Then you have staff shortage. It is not only in a small healthcare organization, it is a common problem everywhere. You have one team member given multiple responsibility, so the chances of them committing error becomes more. And then high patient volumes. Again, pressure of work. They have to make sure they work quickly because they have to see so many patients and without compromising on safety. Then there's a training gap. So limited because hospitals are so busy, and they find that they just want the work done. They have no time to train the staff. So they have limited access to the updated protocol and the best practices. So when this happens, when there's lack of training, then the chances of errors to happen while they're at the bedside. Then infrastructure limitations is another big constraint for the small healthcare organization. They have space constraint and equipment constraints. So let us look at the evidence-based solution. So now I'm going to look at this practical roadmap to excellence based on 16-point safety framework. So this is based on CDC guidelines and WHO recommendation. It's a comprehensive checklist which is designed specially for small healthcare organizations. And they found that there is a lot of studies done in many hospitals and labor wards. There's been some papers presented where they have used this checklist, and they found that the infection rate was reduced by 40 to 60% with the existing resources. They never went for any high-cost resources. It's a low-cost intervention, but with high impact. And you'll also find this 16-point safety framework. It also gives you sustainable implementation strategies. So now let us go ahead and start looking at this. So these 16-point framework is based on 7 foundational elements. So the 7 foundational elements are, one is clinical knowledge excellence, then hand hygiene excellence, and you have the creating safe preparation environment, then one patient, one device philosophy, then how do you master vial and ampule safety, then protecting critical components, and safe disposal system. So let us look at each one. So under each foundational element, you have 1 to 4 specific checkpoints. So totally there are 16 actionable points for comprehensive safety. And this is designed for immediate implementation in resource-limited settings. As I told you, it is a low-cost intervention. As I go on, you'll realize that these are all nothing, that doesn't involve any high cost. It's all low-cost intervention. Now, let us look at foundation element 1, which is clinical knowledge excellence. So nurse awareness of the drugs is very important. So we always think that the doctor is the one who's prescribing. So he only needs to know about the indication and contraindication and side effect of drugs. No, it is a nurse also who's going to administer the drug, needs to know about the detail about the drug's indication, contraindication, side effect, and the maximum dosage she can give. So when I went to a hospital and I was talking to a nursing director, she was telling me that every day she makes one nurse, they give drug names to all the nurses and they make them present to them. They have to know in detail about every drug, the indication, contraindication, side effect, and the maximum dose. So this is a practice in that hospital. I think it's a very good practice which will improve nurse awareness, which can be done in other hospitals as well. And you can have monthly 15-minute team micro training. So, quick, short training can be done on drug safety updates. The other way to increase nurse awareness is create pocket reference cards for common medication. So you have so many medications which are given, but they could be some common drugs. Just take 10 to 15 common medications which nurses regularly administer to their patients. So this is actually, you can think of the 80-20 Pareto principle, where if they know in detail about these 10 to 15 drugs, definitely they can prevent errors. Major errors can be prevented. So you can create a pocket reference card with these common drugs. You can even have a QR code on the reference card where they can quickly scan the QR code and get the details about the drug. Or you can have a QR code at the nurse's station, where again, whenever they have a doubt about a drug, they can scan it and know about the drug. So this is the latest technology now, the QR code system. And you can also use a lot of WHO and CDC resources for continuous learning purposes. So that is for foundational element 1. Now the foundational element 2 is hand hygiene excellence. As I told you earlier, these are all very simple, low-cost interventions. So hand hygiene excellence is another important thing which has to be practiced. When it comes to hand hygiene, it's very important. They just need to know 3 things: how to do it, when to do it, and what to use. How to do it, when to do it, as all of us know, the 5 moments. So before touching the patient and before the procedure. These 2 before is to protect the patient from getting infection. And 3 after is the other after body fluid exposure, after contact with the patient, and after touching the surroundings. That is to protect yourself. As I mentioned earlier, you have the healthcare worker has to be protected as well. So you have to practice this 5 moments of hand hygiene. Next is the 6 steps of hand hygiene. They have to know all the 6 steps and how to do it, and what are the timings. These 6 steps have to be performed in 18 to 20 seconds. And then what to use. So when the hands are not soiled, then they can just use alcohol hand rub. But if the hands are soiled, they have to do a hand wash. Then of course the jewelry have to be removed below the elbow when they are doing hand hygiene. This is for foundational element 2. Foundational element 3 is creating a safe preparation environment. It's very important to have a clean medication preparation area. As whenever I go to hospitals and I ask them about this, they say we don't have enough space. As I told you, small healthcare organizations can have space constraint, in which case they can have a temporary clean area. That is a simple tray, which they can clean properly with alcohols for and use that area to prepare the medication. So never prepare the medication in a area which is mixed with contaminated items or near wash basins, and make sure that they know the regular cleaning and disinfection protocols have to be known. So having clean, safe injection preparation area is important to prevent infection. Then coming to foundation element 4, 1 patient, 1 device policy. Never reuse a needle or a syringe on more than 1 patient. So once you use a needle and syringe for 1 patient, discard it immediately. A new needle and a new syringe has to be used for each patient and for each medication. There's no exception. Even for the same patient, is going to get additional dose. You give 1 injection with 1 needle and syringe, discard it, and load another medication, another syringe and needle. So that even there you can't change the needle and use it for the same patient. And when using single dose vials, ampules, and IV fluids, it has to be used only for 1 patient. It includes also for the pre-filled syringes and insulin pen. It holds good for that as well. So one patient, one device policy is very, very important to prevent cross-contamination. Then foundation element 5, mastering the vial and ampule safety. So when it comes to multi-dose vial, obviously they're going to use take medication from same vial multiple times. Every time they're going to draw medication from the vial, they have to scrub the clean the septum. It's called scrub the hub. They have to take alcohol swab and scrub the hub, scrub the septum minimum of 15 seconds. This is again evidence based. If you do it less than 15 seconds, the septum is not going to be free of microorganisms. It has to be done for minimum of 15 seconds. And then usage of multi-dose vials is once it's open, it has to be discarded within 28 days. Even if it is within the expiry date, if it's 28 days is over, it has to be discarded. Or when you think it is contaminated, even before 28 days, if you think that vial is contaminated, you have to discard it. So ideally, what you can do is write the date of disposal, when it has to be discarded on the thing. Rather than writing a date of opening, you can also write the date when it has to be discarded on the vial. So as soon as that date is reached, it has to be discarded immediately. And again, dedicated multi-dose vials for individual patients. So don't, just because it has multiple doses, it can't be used on different patients. To try as much as possible to use a multi-dose vial for the same patient. Then when it comes to ampules, it's very important that before breaking open the ampules, the neck has to be clean. Take an alcohol swab, clean the neck. It's a similar fashion for minimum 15 seconds. Scrub the neck of the ampule and break the ampule open by snapping. If it is pre-scored, of course, it's easy to snap it open. Otherwise, you can use an ampule cutter and then snap it. Take a gauze piece and place it on the neck and snap it open. No tools are needed for this. Then foundational element 6, protecting the critical component. Is very, very important, this aspect, because all of us know that two types of procedure. One is a clean and the sterile procedure. When it comes to sterile procedure, it is sterile to sterile. You have to wear sterile gloves, sterile gown and all that, and you're going to use only sterile instruments. Whereas when it comes to clean procedure, you have to make sure that you have to follow the aseptic non-touch technique. Let us see what it is. That is protecting the key parts. The key parts are like the hub of the syringe, the needle, the needle, and the cannula of the IV, cannula or any catheters, the catheter of the central line or the urinary catheter. All those parts are all key parts. Those parts should not be touched. And if you see in this figure, you know that when you prepare for any injection, once you open the syringe, you cover it with some cap or put the needle back. And it's best would be to place it back in the cover. So whichever you open it, inside of the cover is sterile. So you take it, load the drug, cover the hub, and place it back in the thing and keep it in the tray for administering to the patient. So that is how we need to protect the key parts. Then when we're using IV sets, the IV tubing and the connector should never be left uncovered. They should always be covered. And you can use disposable cannula stoppers to cover them. Every time you have to access the IV, you need to open it, access it, and cover it with the sterile cannula stopper. But ideally, you can use something called the needless connector. It's also the...
Excuse me, madam, we have 8 minutes left.
Okay, so we have something called the Q site, which is a needless connector that can be used. So where you don't have to take it out of the cannula, you can just remove the IV thing and give the injection through the Q site, through the needless connector. So that is the ideal way to use it. And then avoid pricking IV bags. This is a very common practice. Once they use IV fluid started, they find some fluid remaining. They tend to prick the bag to let the remaining fluid go. They don't want to waste that. But ideally, that should not be done because the chance of infection is there. So, and it's better to use collapsible bags. So, and when I suggest that to people, they say collapsible bags are more expensive. It is not so. And I found out that both you can check with your the stores people as well. Both collapsible bag and the other ones are all the same MRP. And or you can use IV sets with vent. So there's just a cost of 30 rupees difference. IV set with vents maybe 300. The other plain sets are 270. So you can try and use sets with vent so that you can keep the vent open and not to prick the bag. Foundation element 7 is safe disposal system, where using foot pedal operated bins in the injection preparation area is useful, where you can open the bin and directly dispose your injection preparation waste. Then using puncture-proof containers. So always carry a small puncture-proof container with you when you're administering injections so that you can directly dispose the needle at the point of care. And of course, Pollution Control Board guidelines compliance for sharp disposal should be followed. And needle always should be disposed immediately without recapping the needles. So that's an important point to remember. So this is the 16 point. As I told you, I just covered it as 7 foundational elements, but it covers all the 16 points which I've listed here. This you can use it as a checklist for your to see whether these are being implemented in your hospital. As I told, the clinical knowledge of the drugs, hand hygiene protocol, it's all listed, which I already discussed with you. It has been listed here as 16 points. Implementation strategy. So as I told you, though we know that these things have to be done, we have to have a strategy. So we could have a 90-day plan for practical implementation. Say probably week 1 and 2, you can do a baseline assessment using this 16-point checklist. Then week 3 and 4, so by doing the assessment, you can identify your gaps. See which part of in this checklist, what is missing, what is that they're not practicing, and give staff training and competency validation can be done in 3rd and 4th week. And week 5 to 8, you can start doing a pilot implementation with daily monitoring. Then after that, week 9 to 12, once pilot implementation done and you find that people have started implementing it, go for a full implementation with weekly reviews. That's about week 9 to 12. Then ultimately it's very important to sustain it. Whatever we are trying to implement, it may be, when I say 90-day plan doesn't stop with the 90-day, it has to be ongoing process. The implementation should be ongoing, for which you have to do monthly audits and continuous improvement. And again, please remember, change will not happen overnight. It's a culture change. You may have processes in place, systems in place, but it has to be a culture change which has to be developed. People have to start understanding the importance of safety of injection and infusion practices. Only then things will change. Then, of course, as you all know, the 6th edition, the key performance indicator has been introduced. So how will you track the progress and impact? You can use HI rates and injection-related infection as one of the key performance indicator. You can use checklist compliance scores by the department as another indicator, or you can use hand hygiene compliance, or you can use reduced length of stay and treatment cause as your key performance indicator. So you can choose any other key performance indicator which you prefer, but these are some of the examples I have given you here. So thank you so much for the patient listening.
Thank you, madam. It is a fabulous session. May I ask you a few questions to start the moderation?
Yeah.
With the great experience you have in simulation training and training nursing staff with various skills, how would you suggest training and auditing staff in maintaining consistency? Because that's a challenge in cannulation techniques and infusion safety. How do you train and maintain consistency in cannulation techniques and infusion safety?
Yeah, first thing, as I told you, is they have to understand what is, like for example, in talking about cannulation, they have to know the best practices. So everybody, see, when any nurse who starts there, when they join a hospital, they are qualified and they say they are qualified nurses. But when it comes to skills, there is a lot of gap. So they need to, when we need good training, we focus on the best practices. Everybody knows how to cannulate. The work is going on regularly in the hospital. Every 3rd patient gets IV cannula. But when you do IV cannulation, you need to focus on the best practice. That is what we talk about, which is based on the guidelines, and it is quality focus. So for example, when you're doing IV cannulation, how do you prepare the skin? You need to use alcohol swab, clean from inside outside, and make sure you select before selecting the vein, do that. And once you clean the area, allow it to dry and do not touch the area again. The simple things has to be followed. And then while cannulating, as I told you, I've seen many staff while they're cannulating, they touch the cannula with instead of just touching the flange of the cannula, they touch the catheter as well. So that contaminates it, because as I told you, that's a key part which enters the patient, which comes in contact with the blood of the patient. So if you touch the key part, it's going to get contaminated. So now without touching the key part, they have to follow, look for the primary and secondary flashback and introduce cannula. And then, of course, make sure it is, after just flush it and make sure it is patent, and then apply the dressing after that. And document, write the date of starting. That's important to make sure when it was started. And continuously monitor, regular checking. Every shift, the IV cannula should be checked for any change in any phlebitis or redness or pain should be monitored continuously. That will help to prevent phlebitis and further complication. Coming to infusion, again, preparing when they're going to start an IV infusion. Spiking and priming is very important. Spiking the bag, as the IV said, there are two ends. One end is a spike, the other end is a part which enters the patient. So both ends have to be protected. As I told, those are the key parts of the IV set. So without, and again, I have noticed staff, they just because they have to use pressure, they hold the spike and put it into the bag. That is again a wrong practice because once it touches the spike, it gets contaminated and that goes into the bag, and that fluid goes into the patient. So that should be avoided. So do not touch the spike, which is a key part of the IV set. And the other end, of course, should always be covered and till it is inserted into the IV cannula. So when they follow the best practices, they can, this, as I told you, it needs training, and we need to have a checklist and make sure that this is practiced at the bedside.
In many departments like the emergency department, how do you balance the need for a quick cannulation and also maintaining aseptic precautions?
Yeah, that's a good question. In an emergency, of course, as I told you, cleaning from inside, outside, allowing, that has to be done for a minimum of 15 seconds and allowing to dry. That is when there is not going to be infection. But in an emergency, obviously, we're not going to be able to do that. So definitely after everything settles, the patient becomes stable, we may have to resite the cannula if you want to make sure that there's no infection in future, especially central line. Central line, what happens is, they may not be internal jugular or subcutaneous ideal, but in an emergency, they may just go in for femoral. So definitely, and of course, they may not follow any aseptic precaution, as you said. So definitely, it has to be resited once the emergency settles, when the patient becomes stable, the cannula has to be resited.
Ma'am, we have two questions in the chat box.
Yes.
Where one person has asked, how do we address so many elements for audit purposes during administration?
No, it's not only during administration, it's the different stages, isn't it? So I was talking about, like you can even take it as performing hand hygiene. First is preparing the injection, have a safe injection preparation area. And then how to prepare the injection tray by using aseptic non-touch technique. And then next is talking about how you're going to administer. So it's a different stages of medication administration, isn't it? So you have to make sure every stage that precautions are taken to prevent infection. So you can, when you're doing auditing, maybe you can take one aspect at one point of time, and then you just make sure it is practiced, and then you can add in more. So though it is put as so many elements, it is just basically performing hand hygiene, which has to be done on a day-to-day basis. That is a very important thing which has to be done. So, but I just split it like that to make it clear and get the message across. Isn't it? Does that answer your question, or?
She is put. I think she says there's a challenge for more manpower during audits. I think your answers actually answered it. I think it's more of a process, rather than the manpower and a stepwise solution. Am I right, madam?
Yeah. So you can see basically in your the team on the floor. Suppose you have 3 staff, and among the 3 staff, you may have one person who is more senior or slightly better. So you can use them as a person who will do the auditing. You can't have a separately identified person who will do auditing in a small healthcare setting. So, but ultimately we have to follow this if we want to prevent infection. And these are all basic, simple things, isn't it? I mean, like for example, as I told you, breaking the ampules. People just take it to near the dustbin and just break it using the cheetle forceps. Just tell them not to do that. So that somebody has to just observe that and make sure it's not done. And again, it's not safe for them and also for the patient.
There's another question. I think somebody says there's a patient who's been operated for cancer, who's had a major surgery, and the patient is now in the ICU and the patient has a CVP line. She wants to know how they will collect the blood from such a patient to do a CBC and a blood culture.
Yeah, I mean, the central line may have different ports, isn't it? Probably from one port, they have to, aspirate, first stop
That's
all
right.
the fluids. Yeah, stop the whatever fluids are going. Then you just aspirate it and then make sure you just take the blood and then flush the line again. And then continue with the whatever medication the patient is getting.
Just another question. Like how many pricks and how many attempts can you do before you change when you're trying to secure an IV line?
Yeah.
How many pricks and attempts can you try before you change the IV cannula?
Yeah. So you, one person, you can just try maximum 2 attempts. You try once, and then again trying. It's not just pushing the cannula in and taking it out and going back and forth. I've seen that. Or once a cannula is in, once a needle is out, they push the needle back. That is very, very dangerous because when the needle is pushed back, it can shear the cannula and it can get they can get catheter embolus. So once a needle is out, and if you find that it is not in the vein, just take out the cannula. And of course, and nowadays you have safety devices. Once the needle is out, you cannot reuse it. You have to use another cannula. And you can try one more attempt. Coming to attempts, maximum 2 attempts. If the cannula, once the cannula is out, you have to change the cannula. More than 2 attempts, you have to escalate it. You have to get help. Don't try again, more than 2 attempts.
And then the IV tubing, when you give IV fluids,
Yeah.
how long can you use the same IV tubing and what are the guidelines?
Yeah, so regular fluids like colloids or crystalloids, if you're using it for a period of a week or so, every 3 to 4 days, maybe you need to change. Otherwise, you can use it up to 3 to 4 days. And after 3 to 4 days, if the patient needs more fluids, then you can change IV set. Otherwise, it's just but short duration. When you tend to keeping disconnecting and reconnecting, then it's better to change every 24 hours. That's
Thank
it.
you,
And if
madam.
you're using TPN or blood and all that, every pint of blood, you have to change the set. Fresh set should be.
Thank you, madam. It was a wonderful session, very informative.
Thank you so much.
And very educative as well. And I'm sure it must be useful for everybody else here and enlightening. Over to you, Dr. Roy.
Thank CAHO
Yeah.
for giving me this opportunity. Thank you so much.
Good evening again.